Brilliant. So Lindsay has started recording. We've got apologies from Louise Lester, and Hayley has kindly joined us. So welcome to the March 2021.
Sorry, Chair. Can I? We've also got Mr. Kumar's apologies as well. He sent them yesterday. Sorry.
Oh, sorry. Thanks, Linz. So apologies from Mr. Kumar as well. Sorry. Welcome to the March 2021's Bassetlaw CCG governing body. Idris has indicated that he has a management trainee that's joining him for the day, doing a bit of shadowing. So that must be Miss Newton. So welcome. Let's do a quick round of introductions. I'm Eric Kelly, GP in Retford and Chair of Bassetlaw CCG. I'm going to start at my top left-hand corner. Hayley?
Hi, I'm Hayley Tingle, Chief Finance Officer.
Kathy?
Kathy Burke, Interim Deputy Chief Nurse. I'm here on behalf of Nicola Ryan, the Chief Nurse.
Okay, Lindsay Britton? You're on mute.
Hi, I'm Lindsay Britton. I'm one of the GPs on the board for Riverside Surgery.
Sue?
Hi, I'm Sue Sunderland. I'm the lay member for Audit and Governance.
Sam?
Hi, I'm Sam Senior, lay member for Patient Engagement and Primary Care Co-Commissioning.
Hession?
Hi, Hishan Harisain, Clinical Director for the CCG.
Sarah Beard? Being all coy and shy.
I was on mute, sorry. Sarah Beard, Assurance and Engagement Officer.
Linz?
Lindsay Blaylock, Senior Corporate Governance here, providing admin support.
Okay. Kumar?
Hi, I'm GP, governing body member and work for Loud Health Partnership. Thank you.
I guess you know Idris as you're shadowing him. Victoria?
Hi, I'm Victoria McGregor Riley. I'm the Deputy Chief Officer for the CCG.
And Ms Newton, would you like to introduce yourself?
I am Joy Newton. I've just joined the Sheffield ICS for 2 years as part of the NHS Graduate Management Scheme. Yeah, and like you've said, I'm shadowing Idris today, so thank you ever so much for letting me come along.
You're more than welcome. So, welcome everyone. Are there any changes to the Declarations of Interest register? Nope. Sarah, no questions from members of the public. Was the email we got yesterday? Any change overnight?
No change, no.
Thank you very much. I can confirm that we're core. So now on to minutes for approval from our last meeting. Just get them up on the other screen. Sorry, 2 seconds. Okay. So minutes of our 19th of January meeting. Page 1, 2, 3. Looking for Hession's hand. 4, 5, 6, 7, and briefly page 8. Any queries or comments? Fantastic. And minutes of the short meeting on the 16th of February, page 1, 2, 3, 4, and 5. Any comments? All take it as no hands are up, so take it as everyone's happy. So minutes have been approved. Action log. A few items on it. Finance performance and activity is kept on post-pandemic. next two items have been deferred around efficiency plan update and rapid diagnostic centre. Next is temporary consolidation of some paediatric activity at Sheffield Children's Hospital during the current lockdown. Is there any change or updates there?
So there's no change. Children's torsion of testes are going to Sheffield Children's Hospital. Transferred there as required from a Doncaster and Bassetlaw perspective. If the child is from elsewhere, there are different arrangements. So Barnsley, for example, are doing them during the day, but not at night. But for us, predominantly Sheffield Children's Hospital.
Brilliant. Thank you. I suppose that will raise a few questions going forward, but I think that will be covered at the joint committee at some point in terms of sort of paediatric urology and the stance at DRI, but we'll cover that after the pandemic has eased. Sue, governing body assurance framework and risk register.
Yes, sorry, didn't have time to provide a written response, but it was discussed with Idris and the IG group and also at audit committee last week, and general agreement to reduce the risk from an impact of 5 and a likelihood of 4 to an impact of 4 and a likelihood of 3, recognising the fact that we've provided staff with a lot of resources to be able to work remotely, and actually the level of staff absence through sickness has been relatively low, but it remains a risk as we continue to go through the pandemic, but we've reduced the size of the risk substantially.
Thank you for that update, Sue. Any questions or comments? No. Oh, thank you. Moving swiftly on, Chair's update followed by Idris's update. It's yeah, largely everything still concerns ongoing COVID vaccination program, which has been undertaken locally by our free PCNs, with the current debate around whether the PCNs will carry on and vaccinate cohorts 10 to 12 or whether they won't. I think a decision has to be made by close of play tomorrow by each of the PCNs. So we'll await their decision making. Otherwise, the vaccine program seems to be rolling out fairly swiftly within Bassetlaw, with none of the international issues around the AstraZeneca vaccine being seen, as far as I'm aware, locally. So all good there. I'm sure Idris will update further, and our cases seem to have plateaued off locally, which is reassuring as well, despite the occasional blip amongst a couple of local care homes. The other big issue is in terms of the sort of CCG's future, the merging of CCGs into ICSs, and the current debate that's ongoing in terms of where best will Bassetlaw fit. Will we be part of the Nottinghamshire system, or will we remain part of the South Yorkshire and Bassetlaw ICS? There seems to be a lot of conversations going on regionally and nationally, and we await the outcomes. I know Idris is having numerous conversations with colleagues both northwards and southwards to actually ensure wherever we sit, we will work and strive to actually get the best outcomes for the independent state of Bassetlaw, and we will do whatever we can to actually maintain as much independence and local determination around what's best for our place. Hand over to you now, Idris, for your update.
Thanks, Eric. So I'm conscious that the items in my update also appear as items for the agenda, so I'll keep this part brief so we can go into more detail when we get to the main agenda items. I think the thing that I wanted to highlight most is probably just a general statement of thanks and appreciation both to the PCNs for the fantastic work, particularly around the vaccination programme. As we know, Bassetlaw was the first PCN in Nottinghamshire to start the vaccination programme, and that's continued as fast as we can get the vaccines, which is at the moment been our sort of only rate limiting step. But I'll go into more detail later on in the agenda on that. But also I wanted to thank wider stakeholders. Our partnership arrangements with organisations like the Bassetlaw Community and Voluntary Service and the District Council have always been strong. They've really come into their own during the whole of the COVID pandemic, and the closeness of those arrangements and the mutual support has really been fantastic. And I know the community and voluntary sector and individuals have been helping enormously with stewarding, sort of supporting the vaccination programme. So a great big thank you to the Bassetlaw public as well for everything that they've done in support of this. So I just wanted to say that really at this point, but like I say, I will go into more detail about each of these issues, the vaccination programme, the late rates of COVID currently, and the latest on the integrating care sort of work later on the agenda.
Thank you, Idris. Any questions or comments for Idris at this point? No. Okay. Kathy, quality and patient safety update.
Yeah, it's a short update from Nicola, but it's focused on the continuing healthcare processes within the CCG and highlights how we've achieved the requirements that NHS England set us in all the areas. So we're really pleased to be able to provide that assurance.
Thank you, Kathy. Idris?
So I couldn't get off mute. Yeah, I just again wanted to extend thanks to the CHC team this time. Yeah, it was actually quite challenging, this, and at one point, partly due to staffing issues before Christmas, it was somewhat off track. But the team put forward, a very strong plan to bring that back and to deliver it, which indeed they have done. So many thanks sort of to the hard work of all of the team for achieving that. It's very, very good news.
Thank you. I'll pass that on.
It is, and I would just like to echo Idris's comments there. Well done, everyone.
Thank you.
Nottinghamshire Best Start strategy, Idris.
Yes, I'm not going to go through the detail of this paper, but important that governing body are aware. So the Best Start strategy has really been developed by, across Nottinghamshire, both with the City Council, Public Health and the community services around that. It went to the Health and Wellbeing Board at the beginning of this calendar year and was very well received. It sets out 10 priorities of the strategy and the activities. They're set out in the main document, particularly on page 2, and then the paper goes on to explain what the significance of each of those, for example, prospective parents well prepared for parenthood, and then the strategy describes how that's going to be achieved, the importance of it, and what the outcomes are. I think the particular reason importance of this, and there's a great quote from Michael Marmot, Professor Marmot, in the paper, that says that the foundations for virtually every aspect of human development, physical, intellectual, and emotional, are laid in early childhood. So what happens during those early years, starting in the womb, has lifelong effects on the many aspects of health and well-being, from obesity, heart disease, mental health, to education achievement and economic status. This all goes to the heart of our very purpose of reducing health inequalities and improving healthy years lived, and it all starts in the womb. So I think a very important strategy, and we look forward to seeing its sort of development and implementation and the long-term hopeful benefits that will accrue from it.
Thanks, Idris. Yes, the first 1,000 days from conception to second birthday are crucial in determining a sort of one's life outcomes, and I know within both the Bassetlaw CCG and wider stakeholders and our ICP, actually getting the sort of best outcomes for children and young people are something that we actually strive to. Just a quick question. As with a lot of things around sort of Nottinghamshire strategies that go through the Health and Wellbeing Board, sometimes Bassetlaw isn't included to the extent that we would like it to be. But actually looking at this strategy and obviously your continued input into the Health and Wellbeing Board, I think we in Bassetlaw can be pleased to be part of the Nottinghamshire strategy.
Yeah, I agree, Eric. I think it's an improving position in terms of Bassetlaw's sort of close involvement around everything Nottinghamshire, and Nottinghamshire's close involvement everything around Bassetlaw. So yeah, it is an improving pitch, and we're an associate to the Children's Commissioning Hub, and that's currently being reviewed, which is quite timely, really, in light of the strategy. And we're a close part of that review as well in terms of what that is going to look like going forward.
Yeah. Got a couple of questions. Heshen first.
Thank you. Just to say, yeah, fully supportive. I think it's a positive step towards the future. I think it'll be positive for everyone involved, really, if we get this right. One of the things that I thought about when I read the paper was, I'm not sure whether it's implicit, but it wasn't explicitly said around health literacy for both parents and children. I think that's a key thing to try and get full engagement is health literacy, and then in terms of some of the outcomes, whether we could include things like educational attainment, trying to improve educational attainment across all aspects of children from young ages to secondary schools, etc. Improve school attendance, again, is probably going to be a proxy measure in terms of health literacy, and health literacy for parents as well, because we know that that is sometimes the biggest barrier in terms of getting health promoted and achieving healthy lives lived. So for me, one of the biggest things, if we can achieve, is some sort of engagement around health literacy, and whether we can incentivize it. Nationally, there's lots of talk now around incentivizing healthy behaviors. There's various things being proposed, including paying people to exercise, etc., etc. So I wonder whether the Nottinghamshire strategy could look into some form of, incentivization for prospective parents and children to actually be actively involved in health literacy. And my last point was in terms of outcome measures. They've mentioned avoidable injuries for 0 to 4-year-olds. I wonder whether we could also include avoidable attendances in terms of A&E and primary care, again, as a proxy measure of good health literacy, because if people are well informed, they'll probably be able to self-care more and therefore rely less on reactive, avoidable healthcare. If that's all right. Thank you.
Thanks, Hesh. Victoria.
Yeah, agree with all the points raised. It was just, it is a really important piece of work, and it will make significant difference to health inequalities in Bassetlaw and our wider community. obviously being part of that and stitched into the DNA about the way the decisions are made and the way that this work goes forward, Idris. I think you've alluded to it anyway, but it's really clear that we need to be strong in the governance arrangements to make sure that we are incorporated, don't we? And I think, again, feeding it into our Bassetlaw Health and Equalities group as well, and also the Bassetlaw Maternity Voices Partnership. So there's some really clear links there. We probably just need to think through what that governance and that incorporation needs to look like.
Yeah, so I agree with all those points. Really helpful contributions, and I'll feed back the issues that Hessian raised in particular, and obviously we'll pick up the points that Victoria's made as well.
Thank you, Idris. Thank you. If there's no other comments, Hayley, finance report and opening budgets.
Okay, thanks for that, Eric. Okay, so I'm just going to take you through. I'm just going to pick out the key points for the report. So the position is at January. So it's always a little bit odd at this point in the year when we've literally got two weeks to year end, and we've got a clear review in terms of performance. So I'll just go through the key risks and where we still are. So I'm still expecting funding sources for the additional roles reimbursement scheme, but our expected surplus is likely to be in the region of about £460,000. We did take a really prudent approach early in the year around prescribing, and that was essentially down to the volatility. Also, in terms of continuing healthcare, because we've got the hospital discharge funding, what we've had is we've had less patients which have then been subsequently assessed for continuing healthcare. So our forecasts were quite high there. We are expecting to achieve the mental health investment standard. And I'm just going to pull out just the few risks that are remaining really up until year end. So I think the key risks are we've still got the local authority rebasing value. So conversations are now happening, but we haven't got full resolution in terms of that. In terms of we've still got a potential of clawback of funds, although I think that's looking increasingly less likely as the weeks go on. So I think we will land with a surplus position. In terms of, we've got some additional costs in terms of independent sector activity, mainly because of the acute activity that's built into the forecast position. And I think the final one really that I want to just raise, and again, I think this is less likely as the weeks go on, the hospital discharge funding, there was a set amount of money and it may become unaffordable at a national level. So therefore the funding won't be forthcoming for the CCG. But again, I think that's less likely. So I think we will possibly land with a surplus, but I think one of the key things that we do need to sort is that local authority rebasing value. So hopefully we'll get some resolution fairly swiftly on that one. I don't want to say anything else. I'm really happy to answer any questions in terms of where we currently are. I think what we've also done, or I hope that we've done, or I've done, is kept the audit committee and Sue fully briefed in terms of the journey that we've gone on this year, because it has been incredibly odd at times. But I think getting to the position where we're likely to land, I think is testament to the finance team and the diligence that have been displayed really. Unless there's any further questions, Eric.
Well, thanks, Hayley, and once again, thanks to Michelle and yourself and the whole finance team. If you can express my thanks on behalf of the CCG and governing body to them. They do an incredible job year after year after year. It gets harder and harder, and they perform incredibly well. So thanks to them. Sue first, and then Hesh.
Yep, I just wanted to confirm that Hayley and Michelle have kept the audit committee well briefed throughout the year, and we've had good discussions about the risks that are involved. And in fact, last week at audit committee, we had specific discussions with Hayley around the financial risks, both for the current year and also sort of looking forward to next year. So I feel we're well briefed and we can provide the governing body with assurance that the finances are being well controlled in a very unpredictable time, because the rules keep changing.
Thanks.
Yes, Sue. Thanks, Sue. Hesh.
Hi, thank you. Just one question, if that's all right. In relation, I'm particularly interested in relation to the discharge to assess and transitioning to CHC query. I know that we've been very prudent, and therefore we estimated a certain number that's not come to fruition. Yeah. Having said that, I wonder whether there's, whether there's more to it. Were people getting access quicker because funding was no longer an issue at that initial phase, and therefore were they getting more rehab, if you like, therefore going back to their pre-admission state much quicker, therefore not transitioning into CHC? Or were we anticipating lots of long COVID patients coming out of hospital and therefore requiring long-term care, which hasn't really come to fruition so far? Or is it a combination of both?
I'm not sure, Hesh, and I think probably Nicola, I don't know whether Kathy can answer, but particularly Nicola probably would be able to answer some of that. All I can say from a financial point of view is I think across the CCGs we've been pretty consistent in terms of the forecast that we've done. We've all got the same position, so you might well be right. There might have been some clinical reasons in terms of why we've overestimated. I think it's probably the finance people. I think we've just being probably overly prudent, if I'm honest.
Okay, I mean, anecdotally, from my perspective, compared to previous years, when patients have been discharged, as a GP, you often get queries from families saying, they've been discharged, but they don't have adequate support, or support was promised but is delayed currently, which hasn't really been a prominent feature of the last 12 months. I haven't had many families ringing up saying, my mum or dad has been discharged and they don't have the necessary support for the next few weeks, etc., etc. So I wonder whether there's an element of that as well, and therefore people feel more assured, therefore they probably recover a little bit quicker potentially. And my last point, I think it's probably a typo. On page 4 of your report, Hayley, under cash position, it says the last sentence, it says no such prepayments are required to be made in March 2020. I assume it's 21.
It is, yeah, it is, yeah.
Thank you.
Yeah, thanks, Hesh.
Thank you.
Thanks, Hesh. Kathy?
Yeah, thank you, Hayley. I do think Nicola might be able to answer those questions in more detail, but what I do know is that due to the different schemes that have been on offer, there has been sort of a rapid agreement to discharge patients, but also, as you'll probably be aware, or some of you, we've got really comprehensive arrangements in place across the nursing team. So on a daily basis, one of us is basically on call to look at discharges and to agree packages. And it's my turn today, for example. So we try and avoid any delays whatsoever in that.
Thanks for that, Kathy. Hopefully you'll have a quiet on-call day today. Thank you. Thanks, Hayley. Sticking with you, opening budgets for 2021-22.
Yeah. So again, we're in a very different situation than we would have been this time in previous years. So this is a really brief paper, just more for consistency, really, that we've always brought this to governing body before. So what we would normally ask is governing body to approve and sign off budgets at the start of each year. But because of financial planning for 21-22 being deferred, the current financial planning regime, we've been told will be at least until June 2021, but it's expected to be beyond that, at least I think into September. Now, something did come out yesterday, but I've not yet had a chance to read it, but I'll touch on that in a minute. Our allocations are yet to be announced, so that is likely to be a combination of place allocations and system allocations, as in months 7 to 12, which was September to March 21. So there is more information expected. And as I've said, I think something came out yesterday, but at this point in time, because I've been on leave, I've not had a chance to look at it. So I'm not sure what that at this point says. So fingers crossed we have got some more clarity. Once we do understand what that means, we'll very, very quickly undertake an exercise to agree the budgets at an organisation level, and then the subsequent impact from a system level as well, and we'll present something to governing body. But for the purposes of this paper, we're just asking governing body to note the update and note that as soon as further information becomes available, we will present something to governing body. So hopefully it might be next month, so fingers crossed.
Thank you, Hayley. Any questions or comments for Hayley? No, thank you, and thanks for, again, Hayley, for coming in during your annual leave. It's much appreciated.
No worries.
Performance, Victoria. Dr. McGregor Riley. I suspect she might have had to sneak onto another call. So shall we defer Victoria for a minute and address integrated care engagement?
Yes, thanks, Eric. If Victoria's got connection problems, because I know she has had issues with her broadband or narrowband, I think it is, then I'll take the performance item, but we defer it for now and hopefully she'll be able to rejoin us. So on integrated care, as governing body knows, the white paper was published and there is now a bill that will be presented. Victoria's just informed me that her computer has stalled, so hopefully she'll be able to restart it. So the white paper's been published. We've got a pretty good idea now in terms of the direction of travel. In terms of the timescale, we would expect the bill to achieve its first and second readings probably in May. But it's although as legislation it could go through to being in law as an act quite quickly. As you can imagine, there's a reasonable sort of backlog of work in Parliament, and it therefore may take, you know, sort of several months for it to actually come into law. But that's, I don't think, is a material issue for us. I think there's a lot of work that we need to do. So we are working at the moment on each of the 5 places to develop sort of the governance and the arrangements in each place. For Bassetlaw, we anticipate that will be a development of what we've got already. So very strong partnerships, broad partnerships through a series of different forums, so we can really get that breadth. I think we're one of the few sort of places in the country that have got such strong partnership arrangements that extend even to Department of Work and Pensions and fire, police and so on, local colleges. But in addition to that, we'll obviously continue to develop the PCNs. As governing body knows, we established PCNs before people thought of PCNs, so we're a year ahead of the game, but there's still much more I think we can do with joint partnership working at PCN level, but also the provider partnership. And this is described quite often as being a vertical integration at place. And by that, it means working together at provider level across mental health, community, secondary care and so on, as opposed to at system, we're looking more at horizontal collaboration, which is all the secondary care hospitals, for example, working together. So that work continues. There is a draft maturity matrix that has been produced now, and we're expecting that to be finalised within the next couple of weeks. And I think we can use that maturity matrix to look at those areas that we want to concentrate on in Bassetlaw. At a system level, the governance arrangements are being planned, are developing. A compact has been drafted, which would be basically a bit like an MOU, so a commitment by all partners, including local governments, providers, and so on, to work together and to work together in partnership and towards sort of a quadruple aim, as we're describing it. So that's about the sustainability financially, but the quality of care that we provide, but also health inequalities and healthy years lived. And I think that's a really important element. That's something which has been sort of the mainstay, I think, of our work in Bassetlaw, is reducing those health inequalities. I'm very pleased that the draft of the compact has got that quite central from a system perspective. And from a commissioning point of view and a CCG point of view, we're getting greater clarity about what this will mean for our staff, for example. So it's now clear that not only the functions, but all staff will transfer to the integrated care system, and all of those not on governing body will have employment protection, which I think is a really, really welcome and important issue for us. Looking after our staff, I think, is absolutely critical, and certainly, you know, the commitment that has been shown by everybody over the last year, but for us since the CCG was formed, has been exemplary, and I'm very pleased that we'll be able to protect the security of all of our staff. It's quite likely that some of those functions then will be delegated back or seconded back in some cases back to place. So we're looking at having very strong identities and a high level of sort of freedom and authority to act at a place level. And I think that's particularly important for us in Bassetlaw, because we work across two systems, as was alluded to earlier in the meeting. And on that point, the discussion nationally about boundaries of ICSs and co-termosity with upper tier local authorities continues. So I can't tell you today exactly where that's going to fall, but it is a conversation that is very actively being had at national level. And we know that there are pros and cons from a Bassetlaw point of view to either being in the Nottinghamshire system or the South Yorkshire system. And you'll have heard me say many times that actually we're in two systems, and we'll always be in two systems, because that's what works for Bassetlaw and the Bassetlaw residents. But I think it's important that we also recognise that whereas some, like the County Council and Notts Healthcare, see a real advantage of Bassetlaw Place being in the Nottinghamshire system, that is also balanced off with South Yorkshire and Bassetlaw system wanting Bassetlaw very much as part of the South Yorkshire system, and the District Council similarly very much wanting us to stay sort of in South Yorkshire. So there are pros and cons. There's strong arguments on both sides. I'll keep you updated with the discussions that take place, and as soon as we get a clearer idea about our destiny, I will inform you as well. So coming back briefly to timescales, like I say, hopefully legislation starts to go through in May. We're expecting further guidance, first of all, from an HR perspective in terms of HR principles, probably in April, so just a few weeks' time. But then there'll be sort of further HR guidance, but once the bill, I think, has had its first and second readings in the House. So you're probably talking about the end of May, beginning of June. We are anticipating that the formal structures in terms of the new organisations will be clear and agreed by all parties, probably by about September. So that's the timescale that I think is quite critical for us. And therefore, from September through sort of October, we'll start to formalise the alignment of staff. And I'll be having a briefing with staff, hopefully tomorrow, just to bring them up to date with more details of that. And we are anticipating some more information that's been agreed across the integrated care system of South Yorkshire and Bassetlaw that we'll be sharing. And if Eric and I, as chair, Eric and I, could send out a joint communication to our staff, informing them of the latest, sort of picture, that would be helpful. I'll draft something up for tomorrow on that. So I'll stop there and happy to take any questions.
Thanks, Idris. Any questions or comments for Idris on this?
So the one question I thought people may ask, but haven't, is where the protection for people the line is drawn, because it states in the FAQs from NHS England and the guidance we've received so far that it doesn't extend necessarily to members of governing bodies, but it doesn't define the membership of the governing bodies, and different governing bodies have different membership. So there are statutory roles in governing body which are common, and then there are discretionary ones which differ. So we have fed up through to the national team requesting clarification on that, and as soon as I get that, I will inform you.
Thanks, Idris. Okay, if no questions or comments, we will move swiftly backwards onto performance, if that's okay, Victoria. Glad to see that the connection has returned.
Yes, apologies. My computer did that freeze thing where I just can't touch anything, and so I'm really sorry about that. But I was desperately trying to unmute and video myself, but it wasn't happening. So hopefully that won't happen again as I go through this. But if I do suddenly disappear or anything, please forgive me. I am expecting a new laptop anytime soon. So I'm just going to go through, I think, the most salient points, if that's okay, Eric. I'll start off with A&E and the 4-hour wait target. Currently, we're sitting at a year-to-date position of about 91%, which actually comparatively, I think, is fairly good compared to other peers. We've seen that our daily averages since 1st of April are now about 110 patients per day. This was about 148 at the same time last year, so less than last time. But we have seen an increasing number, so those figures are creeping up throughout February into March. So the average 7-day moving average is about 116 attendances per day, although just lately it did dip towards the end of last week. So again, fluctuating position, overall seems to be coming back up to pre-COVID levels, but still not there yet. We are doing a piece of work as well to make sure that we're keeping an eye on who's attending and for what purpose. Our initial data seems to suggest it's very similar to the reasons in pre-COVID times, but we're particularly interested in looking at children attendances and mental health related attendances. So that's a piece of work that's going on at the moment. In terms of 18 weeks RTT, again, not where we'd like them to be, but we know the reasons for that. So as of the beginning of March, the 3rd of March, we had nearly 400 patients waiting 52 weeks or more. The vast majority of those who are related to TNO and MSK and DBHT. But we've got 55 patients waiting 52 weeks or more at other providers, the majority of those being at STH as well. However, there are some specialties where there has been an improved position and the 92% target has been met. For example, geriatric medicine, neurology and thoracic medicine. And we've got improving position and recovery in other areas such as, for example, dermatology and rheumatology. So we do know that some good effort is being made by DBHT and other acute colleagues to try and improve performance around RTT. We know that the issues have been affecting performance has been about, COVID safe working environments being maintained for staff and for patients. And obviously the step down of all non-urgent elective activity due to upper 4 guidelines. The kind of work that's happening to try and improve the position or extensive review of insourcing and outsourcing for extra capacity, using independent sector providers where we possibly can to improve the position. There's been a reopening of Ward S10 at the DRI from February, and Park Hill are able to manage more category 3 and 4 patients as well. So hopefully that's also in line with the wider initiatives that are happening at SYB level. DRI are also stepping up elective operating as well, so that they can offer more capacity for routine operations. And there's a wider capacity planning process underway, which should be due for completion in the next few weeks, so we can feed back on that at a future time as well. In terms of diagnostic weights, obviously we still continue to be very challenged, particularly in certain areas which again we know about. The non-obstetric ultrasound, MRI, CT seem to be the worst areas of performance. And again, we know that there's a lot of work happening on a wider SYB level to try and ameliorate the risks around some of that for patient care. Some of that activity has actually been caused in a positive way by increasing 2-week wait referrals, which is always good to see, knowing that we did have a backlog from the COVID period. So 2-week wait, urgent and routine referrals have increased for MRI, and urgent and routine have also increased for non-obstetric ultrasound as well. In terms of restoration planning, there's going to be some more MRI days, mobile MRI days put in February and March. So there'll be more capacity coming on stream right now. And there'll be further additional sessions to be run in-house, partly because of the additional investment that we've agreed as CCGs with Doncaster, with DRI as well. In terms of cancer standards, we do continue to have some breaches, unfortunately, particularly around 62-day standards. Of those 5 breaches, we do know that those breaches were minimal, as in the days waiting, so not good to see, but we do know that we're trying to do the best that we can to keep those breaches low. One of those issues being particularly around capacity in breast cancer services that we're hoping has now been managed appropriately. But again, what we're finding is that the offer of mutual aid and support and use in the independent sector is improving the overall position for cancer waits. Just a few other things I just want to mention, possibly going down to IAPT. IAPT, we continue to do super well. We are really well serviced by our IAPT provider, and at a time when we know that mental health need is going to be increasing, that's particularly good to see that that performance continues to be really good. Dementia diagnosis rates, you'll notice there has been a decrease in that. I think it was 78% around there last month. It's gone down now. So we continue to need to do some work, I think, with our GP primary care colleagues, because there continues to be some variation across individual practices. And that information has been passed through the primary care team, and we probably need to investigate that a bit more robustly with individual practices. In terms of CAMHS activity, keen to see that we have an overview about CAMHS waiting time, particularly because we do know that mental ill health, particularly around younger children and adolescents, has increased. So we'll be keeping a closer eye on those waits as well for CAMHS services, making sure that we support our provider colleagues to work through backlogs where they've been developed. Stroke again continues to be an area of concern. I'm thinking that needs to again probably be picked up through QAPs. I'll be speaking to Nicola around the performance in stroke as well. We do know that there has been a lot of work to do some root cause analysis in terms of stroke pathways, but I think there could be possibly more to do around sharing that learning with the wider community teams. So I think that's a piece of work we can pick up through QAPs as well as part of a quality initiative. Our SMI checks for LD and mental health are not, again, where we want them to be. We know a lot of reasons for that related to COVID. However, our LD health checks have significantly improved. At the moment, our data is showing about 80% have been completed. So that is actually a really good position and definitely an improved position from where it has been. Whereas SMI at the moment is possibly more around 26% based on the absolute up-to-date data received this morning. So again, more to do around SMI health checks with practices, although practices are very aware of this and are continuing to do the best in the challenging circumstances related to COVID. So I think those are the key issues to bring up, Eric. Happy to take any questions that people may have.
Thanks, Victoria, for that comprehensive update. And actually good to hear that things are gradually moving forward. So thank you, and thank you and the performance team for all the work that keeps going on in the background with colleagues from Doncaster CCG and DVH in particular. Hesh.
Thank you. Just a couple of points, really. The first one was around diagnostics and non-obstetric ultrasound scans. I've seen the data until probably September, October time or so. So in relation to the actual activity generated by primary care, that activity has reduced significantly compared to previous years. It's just the backlog is caused by trying to deliver the service in a COVID secure way, plus coping with absences in the ultrasound department, which was mentioned at the diagnostic CRG. And again, we did some work around non-obstetric ultrasound scans for lumps and bumps and hernias, which myself and Jazz shared with primary care. And the last conversation I had with Doncaster was in February, I think, or beginning of March, and they had seen a positive reduction in the number of requests for ultrasound scans for lumps and bumps, which they were thankful for. So I think we're going in the right direction. I think it's going to take a lot of time to work through the backlog. So that's that one. In relation to health checks in SMI patients, that is on the agenda and radar of SDC, and we're working together at SDC to try and share the learning that we've had with LD patients and how we've managed to go through that, and also giving primary care the flexibility of doing things more remotely like they did with the LD patients, as well as introducing things like diagnostics. So we've had some blood pressure machines now delivered to us via NHS England, and we're going to repurpose those to see if we can capture some of those SMI patients who might be reluctant for whatever reason to come to primary care to have some of those assessments done. So it's a work in progress. I think primary care are aware, and I think they will be focusing on the SMI patients imminently, if not done so already. So I think that will, fingers crossed, will improve. Thank you.
Thanks, Hesh. Any other questions or comments to Victoria? Okay, thanks, Victoria. Communications update, Sam.
Thanks, Eric. Yeah, just the report's quite self-explanatory. Just two things I wanted to pick up on. One was just building on what Idris said around partnership working, and some really good work with partners on comms and engagement, and Kathy's involved with this. We should have some media, a video or animation ready by the next meeting around preparing for adulthood transitioning, and that's involved the Youth Council locally, who've had some great input, and the Crocodile House Media. So I think it's going to be great, Cathy, the media that's come in. So there's positive partnership working. And secondly, I'll invite Idris or Victoria to add in around the mental health engagement document for transforming the mental health services in Bassetlaw has been shared with stakeholders and via social media channels and the website. So I don't know if Victoria or Idris want to add something on that.
Can do, Sam. Yeah, we've had a tremendous response so far to the opportunity for people to engage around the mental health transformation agenda. I've been off for about a week, but just before I went off, we had it was, I think, about 400 odd responses, so it was tremendous. I've got an update planned for later on today, so I'll find out where we are. But as part of that, obviously, there are ongoing engagement initiatives, not just with wider public stakeholders, but also specific stakeholders in terms of the mental health collaborative group, for example. We've also engaged with our local district council colleagues very, very recently, and we will be also engaging again with our the Health Scrutiny Committee at Nottinghamshire, paper for which has got to be done by the end of this week, so we can go and engage with them in April. So we continue to have both more formal as well as less formal routes to offer people to work with us on this agenda. And obviously, governing body will be formally provided with a paper at a subsequent meeting later this year, hopefully May. Depending on the outcome, obviously, of the consultation, we'll be making recommendations to governing body for a decision in due course. We're also keeping engaged with our NHS England colleagues as well as part of the assurance process that we need to maintain their awareness on and meet the standards around that. So lots of work ongoing, lots of really good feedback that we're receiving. It's really good to know that our community is engaging with us on this. And I think there'll be lots of opportunity for us to take those into consideration when arriving at the future decision.
Okay.
Thanks, Victoria. Thanks, Sam. Sue, Audit Committee update.
Is it me again first, Eric? I don't know. It's Sam on the Primary Care Committee.
I thought it was Primary Care next.
Oh, I've got Audit Committee first, but let's go for Primary Care next.
Oh, it's okay. Quite brief, the meeting from the 15th of January. So we've got the next one at the end of the month. I think the flavour of this report is just shared in discussions around the COVID vaccines and the flu vaccination update. And I've noticed a typo, which is my error, on the primary care incentive scheme discussion is 21-22, and the meeting has been held around that. And I think members are conscious of, resilience in primary care and not putting too much pressure on reporting going forward 21-22. Because a lot of it's going to be around recovery. So, Victoria, did you want to add anything more recent on there?
No, I don't think so, Sam. Just to say that it continues to be a very fluid environment in which we're operating, and thinking about the incentive scheme will also need to be, wider policy initiatives around PCN working, for example, on COVID will need to be taken into consideration. So we'll pick that up at the next PCC meeting, as you mentioned. But I think one of the things that we were all quite clear to say is that supporting reduction in health inequalities needs to be a key focus of whatever we can do moving forward.
Thanks, Eric. Thanks, Victoria.
Thank you. Thank you. Sue, Audit Committee update.
Just waiting for my clock to stop chiming, sorry. Apologies that it's a verbal update, but the audit committee was only last week and the papers had already gone out. But I thought it was better for you to have a verbal update than wait until the next time we meet. We had a good audit committee. It was the committee at which we received the internal audit plans for next year. along with their draft head of internal audit opinion work for the current year. Now, as I think we've told you in the past, there was a bit of a delay in starting the internal audit work this year. They're only doing the very sort of minimum core audit work, and so the interim head of internal audit opinion doesn't actually give a rating at this stage, but that isn't an issue. It's just that they haven't completed enough work, but all the work that has been completed so far has given us either significant or substantial assurance, and they're not anticipating a problem in delivering enough work to give us a head of audit opinion when we submit the annual reports. So it's really just a timing issue, and they've reported good progress on our implementation of recommendations. We're currently sitting at 100%, which shows how seriously we take recommendations for improvement and how we deal with them. We had something new this year, this time from the external auditors, because they're doing a more comprehensive value for money risk assessment this year, where they're looking at some key areas in a lot more detail than they've perhaps done for the last few years. The feedback that we got from the external auditor was very positive. It won't come as a surprise that financial sustainability is one of the risk areas that they're going to do a bit more work in, but that's common across the board in health and isn't helped by the sort of current uncertainties about the planning arrangements going forward. But as far as our arrangements sit in all the other areas, they were very complimentary about the arrangements we have in place and haven't made only one very minor recommendation around how we could just tweak our risk management arrangements that myself and Cheryl are going to have a look at. We also received the draft internal audit plan for next year, which again is going to be very much focused on delivering the core audit for the sort of minimum number of days necessary given the sort of future demise of CCGs and the changes, but we did agree that we would, if necessary, fund any additional work if any risks arise during this transition year anyway. So that's going to be something we keep under review. We had the counter fraud update and their plan for next year, all of which we've accommodated and is fine and builds on what we've been doing previously. All our governance reports provided us with good assurance, and we've already talked about the discussions we had around risk and particularly around the financial risks that we're facing and how those are being managed. So I don't think there were any particular issues that I needed to bring to your attention, other than there's a few risk items and updates that I'll pick up when we actually get to the risk report.
Thanks, Sue. Any questions or comments? As ever, a very comprehensive update. Thanks, Sue. Victoria, COVID vaccination update.
I'm going to defer to Idris. I've been off for a week, and as soon as it changes on a daily basis, I've got the figures, but I'm sure Idris will be able to give you a better update than I will.
I'll give it a go. I'll do vaccinations first, and then I'll update on sort of COVID and COVID rates. One is very much linked to the other. So from a vaccination perspective, we've probably done over 50,000 vaccines now. We get sort of latest figures and share those every Wednesday typically, so just the day before that, but I anticipate over 50,000. In the older age groups, so the brackets of 70, 79, 80 plus, and indeed sort of just below that, the uptake of the vaccine has been fantastic. So we're getting coverage of around about 96% of people in the older age brackets. As you go down the age brackets, it's about 90% in the 60s. And when you get to the over 50s, at the moment, it's around about a third sort of people who are eligible for that. So it's about 40% on 50 to 59 and about a third of the 50 to 54. That's partly because obviously that's the latest cohort, and therefore those vaccinations are still being carried out. There is also lower uptake as we go down the age groups, and it'll be interesting to see sort of where they level off. Hopefully we can get up to the fantastic response of the older age groups in the younger ones. So the 3 PCNs are continuing the vaccine programmes. The supply next week will be, touch wood, significantly greater than we've seen on average. So we're thinking around about 9,000 first vaccines for next week. Compared that to just over 4,000 this week. So you can see the significance of that jump. We're also seeing more people going to the mass vaccination sites. The one in Mansfield and others in Nottinghamshire have now opened up to over 40s. So they can access a vaccine if you're over 40, sort of through those sites. But most of the people who are accessing the vaccination sites, the mass vaccination sites, are actually going to Sheffield. But they're relatively small numbers. The vast majority of our vaccines have been carried out by the 3 PCNs. And as Eric alluded to earlier on in the meeting, PCNs have now been asked, and this is nationally, about their ability and willingness to do the cohorts 10 to 12, and the PCNs will be responding to that in the next day or two. In terms of the spread as well of the vaccination take-up, we've done work to analyse whether there are any groups that are not coming forward or that are not getting sufficient opportunity to get the vaccine. So that inequality work is really important. We've seen nationally that some areas of black and ethnic minority communities have had a lower take-up. Obviously, the demographics in Bassetlaw make it difficult to assess that. Statistically, the numbers are quite small, and therefore we can't really draw any strong conclusions. But what we have done is we've focused on the areas that would be of particular concern, and I think probably speak for themselves. So first of all, learning disabilities. We usually see a relatively low take-up of the flu vaccine for learning disabilities. So a concerted effort by the PCNs has been carried out to ensure that everyone with a learning disability that's registered is contacted, and different arrangements have been put in place sometimes in order to facilitate the vaccines, make it more so less daunting, more accessible to people with learning disabilities. So we're starting to see the rates of people vaccinated with learning disabilities increase. There's also work on homeless, and we've seen a bit of a correlation on deprivation as well. So almost linear, not too sharp, but broadly speaking, people in areas of higher deprivation have a lower take-up. So again, sort of targeting that, and there's quite a bit of comms, yes, have been carried out on that. And the other issue, of course, for Bassetlaw is rurality and about access to that. So we've got the option of the bus, the health bus. If we need to, we've got options of pop-up vaccination sort of in some of the more remote areas of Bassetlaw. So we'll keep an eye and ensure that we get those vaccination rates up in those rural areas as well. But generally speaking, yeah, this is a really good news story and being incredibly well delivered with all the hard work that is entailed in that. And I think we can categorically say now that this is having an impact on the rates of COVID and the rates of admissions. So, comparing the week before last to last week, we've seen about a 40% drop in the rates of COVID and a 49% reduction in the numbers of people being admitted to hospital. Yeah, that is a really steep decline of people who are being seriously ill with COVID. Doesn't mean that we've got to the end of the story now, and I would hate people to become complacent, but it is a good news story. We are seeing now rates in Nottinghamshire of about 94 per 100,000. It's slightly higher in Bassetlaw at the moment, to 117. So we'll need to double down on getting those rates down. And across England, it's 61 per 100,000. So that is a significant decline. It takes us back to the sorts of levels that we saw in the beginning of October. So we're not down to the really low levels that we saw over the summer, but we are heading rapidly in that direction. Obviously, with the schools going back, we'll have to see whether there's a bit of a bounce, sort of back up. But at the moment, the R number is estimated in Nottinghamshire between 0.7 and 0.9. So, you can see why those numbers are declining so significantly. So, great news story for the vaccine. It's having an impact because the research now is indicating that the vaccine not only stops you in the vast majority of cases getting COVID, if you do get it, your symptoms are lower, and you're less likely to transmit it to somebody else. There's three fantastic elements that the vaccine is impacting on, and that, I think, is really what is helping drive the numbers down far more steeply than the previous waves. And I think that's why we can draw the conclusion that it's the vaccine that is giving that an extra push. But of course, face, space, hands remains essential. There is still a risk that we will have another wave come back. And I think, a personal opinion here now, the issue here is that if we vaccinated all the people at highest risk, how could we have another wave, and why are people so concerned about that? And it's a numbers issue. If the rates within communities are so high, then there will be people in the lower age groups that will get it and that will become seriously ill. And there are more people in the lower age groups than there are in the higher age groups. So we've got to keep the rates down in order to stop people becoming seriously ill in the younger age groups. Because although they're a lot less likely to become seriously ill, some still will. So that's why we need to be cautious. But I think there is some light at the end of this sort of very long and dark tunnel.
Thank you, Idris. Any questions or comments on COVID and COVID vaccinations? Thank you. Anything further on flu, Idris?
I'll just give you some highlighted figures, if that's okay, Eric. Not the level, unfortunately, that we were seeing in COVID, and that has been absolutely amazing. But still, nonetheless, very, very good compared to previous flu campaigns. So again, thanks to the PCNs for all the hard work that's still continuing to happen. And we will now start going into our flu preparation for this year now, by the way. So it doesn't end for us, it just rolls into another flu campaign, getting ready for next year as well, for later on in this year as well. But currently, across the CCG, the total flu risk group vaccination rate is about 71%. For the over 65s, a phenomenal achievement has been made at nearly 83%. And as I said, compared to previous years, that is absolutely tremendous, particularly whilst we still continue to be challenged around our COVID responses anyway. Under 65s that are eligible between the ages of 12 to 64-year-olds is just shy of 55%. So, some really good effort continues, and some phenomenal performances. Obviously, we're still trying to encourage everybody to still receive flu vaccination where that's relevant and clinically indicated. And as I said, Eric, we will now be continuing to work with our partners to see if we can do even better for the coming year. And obviously, we'll be thinking about how we, create a resilient vaccination service for both COVID and flu as we move into a more sustainable business as usual approach.
Thank you, Victoria. Idris.
Yeah, just to add, the rates of flu vaccination has been fantastic. The rates of flu have been really low. So we've not had a winter flu season this year. And I think the word of caution around that is, therefore, we don't know what the dominant strains are likely to be this year. So the development of the vaccine is more challenging than ever. And there is a risk that the flu period in next winter could be considerably worse. And that's a concern. So it's going to be really important that whatever vaccination is available is taken. But I think that the other precautions that we've had during COVID are going to be sort of important. So don't be surprised if if the hands face space seems to die away a bit as we get into the summer with regard to COVID. Actually, I think that's the best way of actually reducing the risk of a flu pandemic, next winter. So we'll campaign, I think, and work on that in addition to the flu vaccination programme next winter.
Thank you, Idris. Okay. European Union exit update. Is that you, Kathy, in Nicola's absence?
I don't have anything to add other than what's on the paper, but happy to take any questions back to Nicola.
We have little risk associated from a CCG perspective from the EU exit, and we haven't seen sort of any direct impact on us, so positive in that respect.
Thank you. Idris, committee annual reports to approve.
Yeah, I won't go through all of these. You'll have hopefully had a chance to at least skim through them. I think the broad summary that I would give is obviously these are the formal committees of subcommittees of governing body, and we do these reports annually. Despite COVID, we have retained, I think, a really good structure and governance around the committees throughout the COVID period. And for some areas, taking just as an example, quality and patient safety, we did not stop the work on quality for one day during the whole COVID. And I think it's incredibly important for us to recognise that there's a lot of people who've been working very hard, not on COVID, but on the standard business of the organisation. And actually, the business of the organisation is so important, and this is reflected in these reports. So, whether it be audit committee, and as we've heard from Sue, that committee has continued to function really well. Remuneration committee has followed all the sort of due diligence around the way that it performs, and we have had degrees of complexity in terms of governing body tenures and so on to deal with, and I think that's worked sort of very well. Mentioned quality and patient safety, and the exec committee has continued sort of to meet virtually throughout, and likewise the primary care commissioning committee, a very sometimes sort of complex set of working decisions that needs to be taken through the committee, and it's worked very well. And all of this has been, I think, demonstrated as well by internal audit reports in various areas through the year, which for another year have been really, really positive. And that's, I think, in large part to the work of these committees and to the internal governance arrangements, and to, in particular, note Cheryl's input to this, which has been sort of really welcomed ever since she started in Bassetlaw. And although she no longer works for us, she does continue to provide professional oversight for governance, and that arrangement has actually, I think, worked really well and to our benefit. So I recommend the papers to governing body.
Thank you, Idris. So these are for approval. So let's take them all together. If people are happy to approve, keep your hands down. If people have got questions or are unhappy to approve, please raise your hand virtually. Take these as approved. Thank you. Sue, governing body assurance framework.
Thank you. As you'll be aware, the governing body assurance framework comes to every audit committee, but also comes to governing body at least twice a year, and this is one of those occasions. So I know you get assurance from the audit committee as to the work that goes on around the risk registers and the assurance framework, but we do just need to get confirmation from governing body that you are comfortable with the assurance framework as it stands and the risks in there. So I'm just going to take you into a little bit of detail because some of the risks have changed slightly following the audit committee last week. So if we look at the new risks, there haven't been any changes to these following the audit committee, but because they're new, I would just like, if anybody's got any queries on those, that they feel they could raise them at this point. So has anybody got any queries on the 3 new risks that have been added since you last looked at the detailed report back in November? I think they should all ring true with the discussions that we have on other items in the governing body. So hopefully you're comfortable with those. In terms of section 4, which is the risk to be scrutinised, the first one, which is the issue about capacity and IT resources and the effect on the workforce of the changes, that's the risk that I referred to right back at the beginning under the action arising, where we've agreed to reduce that risk score at audit committee from 5/4 to 4/3, reflecting the work that we've done, but recognising that until all the staff have been vaccinated, there still is a risk around that. Hession, have you got a query you want to raise at this point?
Please, yeah, in terms of the new risks, the LD risk, I think, could be reclassified as low because we've pretty much achieved that target and gone beyond. So I'd probably say that could probably be downgraded potentially. And in terms of the IT risk, again, I support, considering we've not really seen it coming into fruition in terms of workforce, in terms of risks to be scrutinised, I'd probably suggest that could be potentially downgraded as well.
Yeah, well, the LD risk then, based on that, if people are comfortable with that, we'll take that back to QAPs and look at that and make sure everybody's happy with that, and that will update it as it flows through the process. But yeah, you raise a good point there. We've made a lot of progress, haven't we, on the LD health check since this was raised back in November. Yep, and take the points you've raised on the others. Thanks for that, Hesh. So back to the risk we're scrutinising. We've already talked about the first one. Then on the other 3, I think they are still relevant and sitting there with the risks as they are, unless anyone has any issues that they want to flag on that. You can see below that we've continued to have executive leads come into audit committee to have a detailed discussion about the risks that they're responsible for and any emerging risks. And then there are some archived risks, because I think at a previous governing body, I mentioned that the executives had taken the opportunity to have a good review of the risks across the board and look at some of those that have been on there quite a long time as to whether they were still relevant. And you can see that a number have been highlighted for archiving, and the audit committee have considered all of those, and I've been happy to agree that. So just that's for noting for you to be aware of. And there is also an additional risk that's been archived, if I can find the right bit of paper. Yep. I'm going to have to just nip back to my audit committee notes as to which risk it is. Apologies for this. I've just lost me space, lost me bit of paper as to where we are with this. No, it's all right. It's those that are on there. Sorry. It's just those that are actually listed in that report that have all been agreed. Are you happy with those being proposed for archiving?
Okay, if we are happy, can we keep our hands down? If we are unhappy or got any queries, can we virtually raise our hands?
Thank you. That's excellent.
Sue.
Yep, sorry I got lost there.
No worries.
And then if anybody's got any other questions on any of the risks that they've spotted that they've got any concerns about or any questions they want to ask, then feel free to raise them now.
I think that's everyone's happy, Sue. Thank you.
Everybody's happy.
Much.
Back to you.
Thank you. Next, any other business? Idris. Got a email from Lindsay yesterday, was it, around an item for any other business?
We did. I'm going to do what Sue's done, and I've mislaid it.
Good.
So Linz, jump in now and save me.
It's the mental health investment
standard.
Yeah. Do you just want me to give a bit of an overview on this? Okay, so we had two issues in terms of the mental health investment standard, and it was to do with the categorisation of the continuing healthcare, that it fit the definition, and also an issue to do with the ambulance service. Essentially back in 2013-14, the percentage that we put into the mental health investment standard relating to ambulance services was higher than we've subsequently had in the last few years, as we've got much more information. And what we've argued, the baseline was set wrong. So what we've done is we've had quite lengthy conversations with KPMG about those two issues. They've now accepted the resolution. NHS England have agreed to reduce our baseline, which is good. And this letter basically is the final bit, which basically gives the assurance.
Okay, thank you for that, Hayley.
Thank you.
So as a governing body, do we just need to note the letter and note the changes to our baseline?
I think so.
Okay, duly noted, and we get that minuted. Thank you very much. Okay. Any other business? No, so we've got a confidential, so it's 10:28. Shall we have a little 10-minute break? So back at 10:40? Okay for everyone? See you all at 10:40.
Thanks.